The next speaker is my good friend, Dr. Priya Jagia from the All India Institute of Medical Sciences, Delhi. She is the professor and head at the Department of Cardiovascular Radiology and Endovascular Interventions. She has over 165 publications, and her topic is somewhat provocative considering that Dr. Govind gave such a wonderful talk on echo just now, in that her topic is CMR, the role of CMR and T1 mapping in heart failure, is it the gold standard? Over to you, Dr. Jagia.
Thank you, Dr. Sanjaya, for your kind introduction. So the topic given to me is to speak on cardiac MR in heart failure. I'll be focusing on the entire gamut of cardiac MR rather than focusing only on T1 mapping as the name suggested. But we will be talking about T1 mapping in detail. So the previous speaker has already alluded to the role of the upcoming, newer advances in echo. Similarly, we are having a lot of newer advances in MR, which are allowing us to pick up these patients early, prognosticate them. So for the purpose of this talk, I'll be going to focus on myocardial dysfunction as the cause of heart failure rather than speak a lot on valvular heart disease and pericarditis, since we can barely cover that in 15 minutes. So when we talk about myocardial dysfunction as a causative agent for heart failure, the MRI has a very primary role in distinguishing the ischemic versus non-ischemic cardiomyopathy. Besides, it can also be, it's very good investigation for evaluation of myocardial infarct, to look at the perfusion and viability, and it's the gold standard investigation for getting a reference value for the ventricular function, since this is operator independent, unlike echo. So as far as viability imaging is concerned, the aim is to detect the living myocardium, which will bounce back after you revascularize the relevant coronary artery. And we do it in two ways. We give gadolinium contrast and we evaluate the patient after 10 to 15 minutes. The other way is to do just like you do the dobutamine echo, to give dobutamine and to assess the contractile response after giving the dobutamine. So this is how late gadolinium enhancement sequence would look like. So we can see this is the BLA view showing the left atrium and left ventricle, and you can see there is a white infarcted. So whatever is white on late gadolinium enhancement is the infarcted myocardium. So you can see the entire white part of the inferior wall as seen here on the short axis view. So this is a patient with chronic ischemia of the inferior wall. So RCA territory is gone. So as we all know, there was a seminal paper by Kim et al. In NEJM in 2003, which talked about the importance of transmural extent of myocardial star, and was found to have a close relationship with the recovery of the segmental myocardial function at follow-up. And currently, what we use is the 50% as a cutoff for defining the viability. So anything which is having less than 50% transmural infarct, that particular segment is more likely to be viable. For example, this segment is having more than 50% transmural involvement of the infarct. So this is less likely to be viable vis-a-vis this upper segment, which is having transmural involvement less than 50%. Also, it has been found that vis-a-vis LGE or dobutamine cardiac MR, the cardiac MR will not require pharmacological stress. It does not have any risk. It is technically easier to perform and is observer independent. However, the dobutamine cardiac MR has some limitations, just like echo evaluation after giving dobutamine, that if there is already severe ventricular dysfunction present at rest, in that case, the evaluation of contractile reserve becomes a problem. So this is the paper I was talking about by Kim et al., which clearly showed that if the transmural involvement by the scar in the myocardium was more than 50%, then the contractility improvement was far, far inferior to segments which had less than 50% transmurality of the infarct. Comparing SPECT, so stress MR can be done to pick up reversible ischemia, and if you compare it with the SPECT, the spatial resolution of cardiac MR is far superior to SPECT, which is 1 millimeter versus 5 to 8 mm of the SPECT. So something which appears as a complete donut on the SPECT actually may show a small transmural subendocardial infarct on the cardiac MR because of the higher spatial resolution. And it was found that using cardiac MR improved the sensitivity far higher than what it was with the SPECT, which has a lower sensitivity in the range of mid-60s. Coming again, there are multiple studies which have compared cardiac MR versus dobutamine stress echocardiography also. And this is one of the meta-analysis which was published in 2007 in American Heart Journal. And it found that the cardiac MR was superior to dobutamine stress echocardiography with a sensitivity and specificity in 80s. As far as cardiac MR and prognostication is concerned in patients with ischemic heart disease, this is one of the meta-analyses with 4,400 plus patients. And it found that if there is a scar, that is, if there is LGE present, the patient had a much higher risk of developing MACE. And every incremental increase in the scar, that is, every 10% increase of the LV affected led to a 56% increase in the MACE. So you can see how good, how you can prognosticate your patient based on the degree of scar which is found, which can be quantified on the MRI. So it concluded that the prognostic value, there was a definite prognostic value of cardiac MR in predicting MACE in patients who had prior myocardial infarct. So what is it that we do in these patients? We have T1 weighted sequences, T2 weighted sequences, which give you tissue characterization and pick up edema. We have late gadolinium enhancement, which can, as I told you, can pick up scar. Now, since last 4-5 years, we also have parametric mapping. So namely, we have T1 mapping, which is used for picking up fibrosis. T2 mapping, which allows us to see edema better. T2 star mapping, which can help us pick up iron and hemorrhage. And then we have ECV. So ECV can be useful wherever there is diffuse infiltrative cardiomyopathy or there is diffuse fibrosis. So this is how LG image is showing infarct, subendocardial infarct in the subcomplex territory, and you can see it is abnormal T1 map. So what we do is we draw ROI in these abnormal areas, and we can find out we can quantitatively have a number of the T1 map, which can be used to follow up these patients later on also. So besides this, parametric mapping is also helpful in picking up microvascular obstruction and myocardial hemorrhage, both of which are associated with worse prognosis and poor recovery after revascularization. So both of them, so T2 star can pick up even small areas of hemorrhage in the myocardium. So this is a patient who had a scar in the septal region, and the T2 star clearly showed hemorrhage. And T2 map also showed edema. So this was a patient who is going to have a poorer prognosis as compared to patients who do not show any MVO or hemorrhage. This is a paper which looked at the native T1 mapping for reversible. So what happens in acute patients, in acute MI, we have edema as well as fibrosis. So you may get LG in both of them. So how to differentiate between acute versus edematous versus fibrosed myocardial infarction. So this is a paper which talked about this, used T1 cutoff values for detecting edematous versus necrotic. And what they found was the edematous T1 scores were in the range of 1250, whereas a necrotic myocardium, that is fibrosed myocardium, was 1400. And using this threshold, what they found was that the volume of the damaged tissue had a good agreement at 6 months LGE, in addition to troponin, and also correlated well with the 6 months ejection fraction. So they concluded that T1 mapping is very helpful to differentiate reversible versus irreversible myocardial injury in patients having acute MI. When can we do cardiac MR in patients with ischemic heart disease? First, obviously, to differentiate it from a non-ischemic cardiomyopathy. And once you have made sure that this is ischemic heart disease, you can do in those patients in whom you want to do viability assessment, in whom there may be a thrombus. So this laminated thrombus is something which can be based on echocardiography. So these small thrombi can also be picked up. You can quantify ventricular function, pick up mechanical complications like these. This is a muscular VSD which can be done. So this is a single study which is giving the entire data, morphological, functional, complication, prognostication of the patient, and follow-up also you can do because there is no radiation involved. However, for the coronaries, because of the spatial resolution which is required, MR at the moment is not recommended for coronaries. Else, for all your myocardial dysfunction, queries you can send the patient for cardiac MR. So let's quickly see two examples. This was a 32-year male patient who had acute onset of chest pain and ST elevation STEMI. And what was found on cath was there was LAT occlusion after the G1. So this was revascularized. And on echo, what was found was the interventricular septum was thickened and had a thickness of around 90 mm. And an MR was done to see whether the patient also had hypertrophic cardiomyopathy. And it showed there was a thickening of the interventricular septum, which was seen. So on T2, there was edema, which was picked up on all the sequences. But when the perfusion sequencing was done, what was seen was that the half of the thickened myocardium did not pick up any contrast at all. So this was something which was suggestive of a thrombus or an infarcted region. And late gadolinium enhancement was done, and it showed that the rest of the myocardium, which was showing some enhancement, now retained the gadolinium, suggesting there was a fibrosis. So there was an infarct in the anterior wall with the underlying adherent thrombus. And so despite doing the revascularization, after the patient came for a repeat MR, what was found was that the anterior wall had thinned out. So it had thinned out as compared to the previous study. So it had not now become normal. And the late gadolinium enhancement still showed the infarct. So this was actually a case of pseudo-HCM as seen on echo. And actually the interventricular septal thickness was because of the swollen septum by edema and microvascular obstruction. And had this was known earlier, the LAD, revascularization which was done could have been prevented. So microvascular obstruction, as we all know, is a no reflow phenomena, and it was ventricular remodeling, is indicator of adverse ventricular remodeling and cardiovascular outcomes, and it has to be. And MR is a very good investigation for picking up microvascular obstruction. Case 2 was a 58-year-old male patient who had chronic stable angina with moderate LV dysfunction, and RCA had 90% non-stenosis. And there was, like I said, there was dysfunction on the LV. So for the viability, the patient was sent for cardiac MR. And as you can see, there was thinning of the inferior wall with no thickening of the inferior wall, as seen on short axis VLA and 4-chamber. Perfusion was done, which showed even at rest, there was a perfusion defect along the inferior wall. And on LG images, we can see total transmurality of the infarct with a thin laminated thrombus in the RCA territory. So this is a patient who will not improve after RCA revascularization. So this is how cardiac MR can help you arrive at prognosticate your patient and can tell you whether you should go ahead with the revascularization or not. So as far as non-ischemic cardiomyopathy is concerned, the MR is very good investigation for evaluation of the myocardial tissue characterization, for which we use T1 and T2 mapping sequences. T1 and T2 sequences, besides the mapping sequences, it gives you a gold standard value of the ventricular function, which can be used for reference for follow-up of the patient, can pick up even subtle wall motion abnormalities, which are very important for certain diagnoses, like patients with ARVC, in whom, for example, the interior RV wall abnormalities, which may not be picked up on echo. It helps to quantify the fibrosis and hence prognosticate the patient. And post-treatment follow-up can be done. And strain now, just like the previous speaker talked about, strain analysis can be done to pick up preclinical stage of the treatment. So it is class 1 indication to perform cardiac MR in patients with non-ischemic cardiomyopathy. Dilated cardiomyopathy, this information is something which you will get on echo also, the chambers, etc. But what is important is the presence of LG. So presence of LG is independent predictor of hospitalization and mortality, and the patient has an increased risk of BTVF and becomes a candidate for ICD therapy. T1 mapping is especially useful when you have diffuse fibrosis. LG is very good for picking up focal fibrosis, but fibrosis, which is depicted by T1 map, it correlates with the ventricular dilatation, the dysfunction, and tells you in patients with DCM in whom sometimes there may be diffuse fibrosis, it is the investigation of choice for picking up fibrosis because LGE may be negative in these patients. For HCM, again, you can quantify the myocardial mass, you can pick up the LGE, you can pick up the gradients across the stenosis, you can quantify the LGE, and you can also guide the treatment regarding septal ablations, and we can follow up after the patient has had his septal myectomy. Family screening may be done, and if on the echo, if there is thickening, the patient may go in MR and can be picked up. So these are certain criteria which tell about the high risk of these patients. So LG is one of them, besides the other parameters which are also seen on the echo. Myocarditis is, again, we have criteria, the modified Lake-Louis criteria, which can pick up both T1 and T2 using T1 and T2 sequences. We can make the diagnosis. So this is a patient we had with ejection fraction of just 25%. Both T1 and T2 values were reduced, and there was typical subendocardial enhancement. So for the etiology purposes, MRI is a good investigation. Amyloid, so again, HCM-like picture, but you see typical diffuse subendocardial enhancement. So this was a patient of amyloid. The endomyocardial fibrosis, typical laminar appearance because of the fibrosis, the thrombus, and the normal myocardium. So trilaminar appearance. So for all the patients of restrictive cardiomyopathy, for the etiological evaluation, cardiac MRI is the investigation of choice. Also, whenever you have a tie between RCM versus CCP, MRI can be done. So real-time full respiratory, while doing respiration, the MRI is done. And we can see a septal bounce which becomes exaggerated in the inspiration in coronary diastole. Prognostic implication of MRI, we already seen as in ischemic. Here also, if you have increased LGE, it is an increased substrate for the arrhythmia. Whereas an absence of LGE, in spite of the patient in spite of the LV ejection fraction being deranged, absence of LGE identifies a population which has a low risk of sudden cardiac death. Strain mapping can be done to pick up subtle abnormalities in patients who have maintained systolic and diastolic function. So in carriers specifically, we can do a strain mapping. So this is a paper in 2006 which mentioned that for all these patients of cardiomyopathy, MRI is the way to go. And now we have even parametric mapping, so the data is even more robust. So I would end by saying cardiac MRI is the investigation of choice for evaluation of non-ischemic cardiomyopathy, and for certain cases of ischemic cardiomyopathy, it allows you tissue diagnosis, helps you pick up the etiology, prognosticate patients in patients having focal involvement. It can target biopsy, and it is also useful for monitoring the outcomes and for doing screening of patients who are genotype positive but phenotype negative. Thank you.
Thank you, Priya. That was an excellent description and overview of cardiac MR in general, and you also touched on some very important points about T1 mapping as well.